Welcome to the Johns Hopkins Women's Health Podcast, A Woman's Journey, Insights That Matter. I'm Kelly Gear-Ripken, and I invite you to listen to Johns Hopkins specialists discuss the latest topics in women's health. Now here's your host, Lily Shockney.
Hi, this is Lily Shockney from A Woman's Journey at Johns Hopkins, and this is our podcast, Insights That Matter. In this podcast, I am joined by orthopedic surgeon Dr. Lee Riley. He serves as the executive chairman of the Department of Orthopedic Surgery and also the chief medical officer of the musculoskeletal service line for Johns Hopkins Health System. And today we're going to talk about back pain. According to several sources, 80% of the U.S. population will experience low back pain in their lifetime, and that back pain impacts 540 million people around the globe at any one time. So welcome, Dr. Riley, and thank you so much for joining us today.
Well, Lily, thank you very much for inviting me. I'm excited to talk to you.
What I found especially interesting is that women between the age of 45 and 65 are most likely to suffer from back pain. Can you tell us why that is?
Back pain really is one of the most common conditions that people face in the course of their lives. Back pain and common cold are the most common reasons for people to seek medical care at any one time. And at the ages between 45 and 65, your back is really undergoing a change. It's becoming more of a middle-aged person's back as opposed to a young person's back. And there's some normal and natural changes in your spine that occur around that time. The discs lose their flexibility. They lose their water content. The discs are a very specialized joint in your back. And then it will put more stress on other joints called the facet joints, and then change the shape of your back and the muscles. So during that period of time, there's lots of normal changes that lend itself to the people having back pain. Now, fortunately, most back pain is limited and will go away with time and with some simple measures to care.
And when we're talking about back pain, I'm assuming that we're primarily talking about lower back pain.
That's right. The most common place for people to have back pain is in their lower back or in the lumbar spine below their waist. That's where the joints move the most, and you have the most stress on your back because that's the area that you use to lift and twist and do other normal activities.
Can you describe for our listening audience what structures make up the back?
Well, you have 24 vertebrae in your back. Those vertebrae have joints in them. And there's two general types of joints that exist. One is the very specialized joint that I discussed earlier, the disc. And then there's something called the facet joint. And you have two of those in your back at each level that are synovial joints similar to your knee or your hip. Around those are ligaments and tendons and then muscles that help the back and the spine move in different ways to carry loads, to allow you to bend, lift, twist, and do other activities. In the spine itself are the nerves, and the nerves run in a tunnel called the spinal canal, and they go from your brainstem down to the base of the spine and your pelvis and coccyx. So it's a complicated and important structure in your back. Your back is an important structure in your body that you use all the time.
Can you tell us what some of the most common causes of back pain are?
Probably the most common cause is overuse. Physicians will often see patients more often after a snowstorm, when people shovel, or when the leaves are falling, after they've raked leaves. So unusual activities that put more strain on primarily the muscles, but then also the joints, tend to be when people have common run-of-the-mill back pain. Fortunately, it's short-lived. Most people don't need to seek medical care for that. Just short rest and the use of an anti-inflammatory medication such as ibuprofen or Aleve, or even Tylenol for a short period of time will usually lead to that pain to go away.
Do you find that, because you mentioned some activities that we certainly do outside, also moving furniture inside rather than waiting for somebody to help us, do you find that it's how much weight is being lifted or how long a task is being done? Or is it actually associated with not bending properly that can trigger back pain?
It's all of those factors, really. Using proper mechanics, keeping your back straight and using your legs to lift is very important. But life presents us with lots of challenges, and sometimes these are challenges that we need to address right away. So moving furniture in your house or moving snow so you can get to your car are all things that we have to do. And it's unusual activities that we haven't trained our back to do that can lead to overuse and strain on the muscles and the joints that fortunately most of the time, as I said, goes away on its own.
When you're making a diagnosis of back pain, what's involved with that? Do you do x-rays? I'm sure you do a clinical exam, probably also a neurological exam. So what are the steps that you take to figure out what's causing this? And then what can we do to remedy this?
First thing to do is to talk to the person who's having the back pain and sort of see how it started, what sorts of things make it worse and better, how long it's lasting, whether there are any associated symptoms such as leg pain or numbness or tingling or weakness. The other issues to ask about are other associated medical conditions that might indicate that there's a more serious problem. If someone's had a history of cancer, if they have a history of an infection, if they have a history of pain at night, other sorts of conditions that would make you think that maybe that those things are affecting the spine. Then you do a physical exam and really check and see what sorts of things make it hurt, what things don't make it hurt. You check the patient's function, their nerves and their strength, their sensation. Often just those measures are sufficient to start treatment. If someone is under the age of about 50, if they don't have any associated problems such as cancer or recent infections or reasons to suspect an infection based on their symptoms, and they don't have any neurologic findings, you often in that instance don't need to get x-rays. You can start treatment, which usually involves some physical therapy to learn back exercises, over-the-counter or prescription anti-inflammatory medications, and occasionally muscle relaxants or other types of medicines to help alleviate the pain.
Can you describe a little bit more how infection may be tied to developing back pain?
So there are rare instances where someone who has an infection at another site, that infection can spread to the spine and cause pain. Those patients often have fevers, although they don't need to necessarily have fevers. They'll have other signs of having an infection. And they tend to have pain that's all the time and really independent of whether they're resting or not. It's often a very difficult diagnosis to make. Many patients with infection, that diagnosis is delayed because it's not immediately obvious.
So you've mentioned a couple risk factors, age being one of them. And as we get older, many of the women listening to our podcast today have osteopenia or osteoporosis. Can you talk a little bit about that and what may be some things that they should be doing to prevent back pain? Because I would suspect quite a few of them are saying, I have back pain when I do this or I do that, but I have osteopenia or I have osteoporosis.
So one thing to say about that is that it's very common in women, and it's important to work with your primary care provider to get an assessment if they feel it's appropriate. That's typically done with a bone density scan or some other scans to assess your overall bone health and risk for fracture. In terms of the spine, I think maintaining as much activity physically that you can, to be active, to go outside. If your doctor recommends vitamin D or calcium or other supplements, to do that. Just be aware that as a woman, you are more likely than men to develop osteoporosis and to develop what are called compression fractures, which are really fractures that are caused by mechanical overload of weakened bones. Be aware that that can happen and that the best treatment is prevention, and being aware that you have it and be assessed for the need for treatment. Fortunately, there are a lot of medications that can be used to strengthen the bones or prevent the bones from weakening that have come along over the last 5 to 10 years. They are mostly prescribed by your primary care doctor or an endocrinologist after an evaluation, and they are very effective. It's important, though, to know whether you need those or not, and that requires an initial assessment.
How much impact does a woman being overweight have on her lower spine?
Weight does have an effect on back pain, and it's both extra load on the spine, but then also maybe if you can remain aerobically active and physically active, that's probably an important counter to that. Weight in and of itself does have a negative effect. But I think even more importantly, it's maintaining a good aerobic conditioning, walking, doing some stretching exercises or some core strengthening exercises of your back and your abdominal muscles, keeping a balanced diet, and getting outside, getting vitamin D from the sun are all important.
When we think about symptoms and differentiating symptoms to determine the cause, can you describe some scenarios for us of what would be the cause of someone having, let's say, lower back pain with the pain radiating down one leg versus just an achiness in the lower back. So how do you differentiate these symptoms so that you can Sherlock Holmes and zero in on this is the most likely probable cause, and then in turn, of course, how to remedy that?
Most people who have, and the majority of people have back pain only, there's usually some kind of associated activity that's brought it on. It typically will last for a short period of time, under 2 or 3 weeks, and then go away. Those are the scenarios that we've been talking about up to now, which are from overuse and involve the muscles and the joints. There are other types of back conditions that are related to other types of conditions that can develop in the spine. So one of them is sciatica. And sciatica is where you have a nerve root that's being compressed and causes pain or numbness or tingling or weakness or all of those things that radiates down the leg and typically below the knee. That can have a number of different causes. The most common cause, which really starts in the mid 20s to early 30s, is a disc herniation. And a disc herniation is where that specialized structure called the disc develops some weakness, and a piece of the disc migrates into the canal and presses on the nerve. It then causes the nerve symptoms, kind of like hitting your funny bone, and the pain going down your leg. Fortunately, most of the time, in about 80 to 85% of patients, over the course of time, those symptoms will resolve and they do not need surgery. They will usually require anti-inflammatory medications and physical therapy, but over the course of about 10 weeks, the pain will go away. The reason it goes away is that your body, when it sees this piece of disc, reacts by creating inflammation. And inflammation is your body's way of trying to get rid of or shrink or attack something that it considers a foreign body. Inflammation is also something we're pretty familiar with if you've ever had a bee sting. So a bee sting causes inflammation and pain, but just like a bee sting, the inflammation goes away, the pain goes away. That's why 8 out of 10 people at about 10 weeks feel better and don't have to have anything done. If it doesn't go away, then the mechanical pressure on the nerve, which is kind of like having somebody step on your toe or having an eyelash in your eye, that mechanical pressure has to be removed. And then that's 15% or so of patients who still have debilitating symptoms for that condition. They require a surgery just to remove that piece of disc that's pressing on the nerve. You don't have to remove the entire disc, just the piece that's pressing on the nerve.
What is that procedure called?
Called a discectomy. It means removing the fragment of disc or the piece of disc, which is usually a small percentage of the entire disc, just a piece pressing on the nerve. So it's called a discectomy. It's a procedure that takes an hour or so to do, hour or two to do. Most of the time you can go home the same day, and it has about a 90 to 95% chance of relieving the symptoms immediately.
And some of our listeners may be familiar with also a laminectomy. Can you describe it?
Sure. So a laminectomy is done for a different purpose. The laminectomy is done when you've developed arthritis in your back and it's caused narrowing of the tunnel where the nerves run. And that narrowing of the tunnel causes a different sort of symptom than sciatica. The symptoms that people develop when they have spinal stenosis, typically it's something called neurogenic claudication. What neurogenic claudication is a condition where when you stand or try to walk, your legs feel weak or you have pain in your legs. And if you sit down, the pain gets better. Often people who have this, you'll notice walking in it with a bent forward posture. And they're doing that to try to reposition those arthritic joints and the bone spurs away from the nerves. So they're trying to walk more closely to in a seated position. There's something classically called the shopping cart sign. So people who have neurogenic claudication and spinal stenosis will go to a shopping cart if they're shopping in a grocery store or in a large big box store and lean over the shopping cart and use it to walk further in the store than they otherwise could. And that's another indication. So in that instance, you need to actually unroof the canal to give it more space. And that's something called a laminectomy. It's also used for other conditions to access the spine for spinal tumors or other things, but that most common indication is something called spinal stenosis.
You mentioned bone spurs. Can you describe a little bit more about what that is and what causes them to develop?
Sure. So bone spurs are arthritis in your back that occur primarily in the facet joints. The facet joints are the two paired joints in your spine that function to allow motion, mostly bending forward and twisting. As you get older and as you develop arthritis in those joints, just like you would develop arthritis in your hands or your feet or your wrists or your ankles, you can develop bone spurs, which are outgrowths of bone that start in the joint and around the joint. They then can cause pressure on the nerves and the neural structures that run next to those facet joints and next to the vertebral body, and then cause nerve symptoms. Arthritic growths of bone adjacent to a joint that occurs with arthritis that then leads to pressure on the nerves that can then cause symptoms and need to be addressed.
Are there other types of surgeries that might be done to help with back pain?
Sure, there are all kinds of different types of conditions that cause back pain. Back pain can be caused by arthritis from scoliosis and progressions of curves in people's backs. And often those sorts of conditions, either scoliosis or in some instances where you've developed arthritis that leads to abnormal motion or slipping of your vertebrae, you need a fusion. And a fusion is a procedure where you grow the bones together. You take the joints, remove the joints, and actually have bone grow across them so that they don't move. It often involves the use of spinal instrumentation, screws and rods to act as an internal brace to both hold the vertebrae still and reposition them in a more favorable position to straighten out the scoliosis or to straighten out the slip of the vertebrae, and then allow the fusion to occur.
What can we do to prevent back pain other than being smarter than we are and not going out there with a snow shovel or picking up a sofa by yourself? Those obviously would prevent these incidences from triggering this, but are there other things that we can do from a prevention perspective?
Sure. One thing I would like to point out is that back pain is part of the human condition, and it's a normal part of the human condition. So that having back pain of a short duration is something that most everyone experiences. The things that you can do to lessen your chance of having back pain or lessen the duration of any back pain that you might experience are a couple. Number one is if you're smoking or using nicotine, stop that, because that really has a negative effect on your spine. It affects the discs and makes them wear out quicker. It has a fairly significant negative effect on the spine, and it increases your risk of having back pain. So use of nicotine, if you can stop it, that really is very helpful.
Does that include secondary smoke exposure?
Yes, it does. I think it's the nicotine dose, but secondary smoke exposure is less of a risk because the dose is lower. It does include things like vaping because, again, it's the nicotine. It's not necessarily how it's delivered, it's the nicotine. So nicotine patches, nicotine gum, cigarettes, vaping, anything that delivers nicotine to your body has that effect. In fact, the research on this involves putting nicotine patches on animals and people to look and see what their risks are. So it's the nicotine in the smoke. Second is maintaining a healthy lifestyle. So trying to keep your weight as low as you can, being as physically active as you can, walking, having some kind of aerobic activity. And then I think using core exercises. So doing some stretching exercises, Pilates, yoga, other things like that help maintain the muscle strength and tone in your body and the flexibility of your body. So those are the basic things that you need to think about doing. The people that I see who are the happiest with their backs, have the least problems, are people who have developed a routine in their life that involves stretching or core exercises or yoga or Pilates. And that serves them well over the course of their life.
I think that we underestimate the benefit of walking. I think if everyone would get out and do some, I think ideally power walking, but any kind of walking, it would help with so many medical conditions. But we discount it thinking that it's not important. We underestimate its value, and that's very unfortunate. Certainly. You talked about smoking and vaping, which I'm quite alarmed about because of teenagers just jumping right on the vaping. Many people have been smoking since they were a teenager, right? And now she might be 60 years old. Do you recommend getting someone into a smoking cessation program, or do you tell the patient now's the time to do the right thing for yourself and cold turkey stop smoking or stop using nicotine?
It's easier said than done. Many of these habits are habits that you've had for long periods of time, and they are an important part of your life. So I think there's no one right answer to that. I think that certainly there are cessation programs that are very helpful, and some people respond well to those, and they can be overseen by your primary care doctor or other specialists. Other people seem to do well with going cold turkey on their own. So I think it's whatever works best for you. I would say that Many of the operations that I do that involve fusions, we actually ask the patient to stop smoking or using any nicotine before we'll operate on them, because there's a correlation between the nicotine and the prevention of the fusion process, which is an important part of the operation to be successful. If an operation that I do involves a fusion and it's not urgent, then I'll have the patients stop smoking and stop using any nicotine and have a discussion with them. And that I realize this is very difficult, that there's no one right way to do it. There's ways that will work for you, and to seek help with cessation programs if you feel that that's necessary.
You had mentioned that two of the most common reasons to see your primary care physician, one of them being back pain. Do you recommend that a patient first see their PCP and be referred to someone like you? Or is it okay for someone to go to, for example, the Johns Hopkins website and type in orthopedic surgeon and go ahead and schedule themselves to see someone like you?
I think most people with short-term back pain, where it's less than 2 weeks or so, probably don't need to see a doctor. I think that they need to be reassured that it's, again, part of the human condition. It will likely get better with simple measures such as just short-term rest, a day or two, and then beginning to take some anti-inflammatory medications over the counter or Tylenol. After that, I think then it's worth maybe seeing your primary care doctor, or at least contacting them and getting their advice as to what to do. Often they'll direct you towards seeing a physical therapist who can begin some core exercises and other forms of treatment that will be useful in the long run. Physical therapy, I think, is really one of the foundations for people to get better and then to stay away from having back pain again. There are good studies that show that regular physical therapy exercises done by someone at home on their own, stretching exercises basically, will prevent people from having episodes again. And if they do have episodes, shorten the duration of time that those episodes last.
I recall, and I'm showing my age here, 50 years ago, when patients would be in bed with a wrap around their hips that had ropes on them that went over the end of the bed with weights on them.
Right.
And they were being stretched in the literal sense. Is that still done in rehab medicine? Or is that now something that we've stuck away in the medical books as we don't use these procedures anymore chapter?
That's something called pelvic traction. And I can remember too, and I'm showing my age as well, patients being put at bed rest for a long period of time in pelvic traction and then having them then get out of bed after a week or two. Bed rest has really been shown to be detrimental to getting rid of back pain or treating back pain. So the recommendations now are to really not do any bed rest if you can avoid it, maybe just overnight, and then gradually increase your activities over time. And the patients who do that, the people who do that have less back pain and it goes away quicker than patients who were put at bed rest. There's a classic study that was done on Marines who developed back pain during basic training, and they broke them into two groups, one that just got up and was active as they could within the constraints of their pain, and others that were given an order to lie in bed. And then they looked at those two groups and they really found that the Marines that were told to get up and move around as soon as they could and work within their back pain did much better, had less back pain than the ones given the order to lie in bed for a week. So activity is important in the recovery of patients with back pain, not being put to rest. Getting back to your initial question about traction. Traction is sometimes used by different physical therapists during sessions. Now, I personally think that it may be useful in relieving some back spasms, but I don't think that it changes the natural history of how long it's going to last or whether quickly it's going to go away. I'm more in favor of doing more active things like core exercises and stretching exercises and getting up and moving around than I am using traction.
What about the application of heat? Because I'm sure that many of our listeners have used moist heat or dry heat, whether a heating pad or a thermocare wrap or something. Has that been found to be beneficial? And is it safe to do for someone to put heat on themselves at home?
The literature would say that heat or cold really doesn't matter. But if it makes you feel better, I would do it. So if you want to have heat or you want to get in a hot bath and that makes you feel better, that is great. It's not, again, going to shorten the duration of the symptoms, but it'll make you feel better for the time that you're using it. So if you find that heat or cold it helps you, I'd say go ahead and do it. But one or the other hasn't been shown to be more effective or even to change really the duration of time that you've had it. But if it makes you feel better for that period of time, it's nice to have an escape.
If someone has been told that they do need surgery, they should strongly consider surgery, what questions should a patient be asking that particular orthopedic surgeon?
I think the first thing the patient needs to do is to really get a clear understanding of what the surgeon thinks the problem is and see if you agree with that conclusion. If you don't, then I think getting another opinion is a reasonable thing to do. Once you've gotten to the point where you recognize there's a problem, have decided that you want to consider surgery, ask them what the alternatives are to surgery and how successful they are relative to the surgery that's being proposed. So what are the non-surgical alternatives that could be considered? How likely are they to help me more than or the same as or less than the surgery that's being proposed? Would waiting and doing those particular non-surgical treatments compromise any surgical outcome or my overall health to wait? So that's another thing to ask as well and to think about. One of the other things to think about in your discussion with your surgeon is to really get a clear understanding of what they would define as success for the operation. Because I've found that my definition of success and the patient's definition of success often aren't the same when we start the discussion. If your definition of success for the operation and the surgeon's definition of success for the operation are drastically different, then you really need to consider whether you should have the surgery or not. So an example of that would be if the only thing you're trying to get rid of is numbness in your foot and you're able to run, walk, you don't have any weakness or pain, that definition of success, and you'd be disappointed if the numbness in your foot didn't go away if you had sciatica or discectomy. Most surgeons would not be confident that that numbness would resolve with surgery. If your definition of success is that you want to be able to run a marathon after your spinal fusion, and you'd be disappointed that you can't run a marathon after the spinal fusion, but in spite of the fact that your back pain's better and your leg pain's better, if that's going to be a disappointment to you, then I think you need to have a frank discussion with your surgeon about what the realistic goals are. So setting realistic goals for yourself for the surgery and understanding what the realistic goals the surgeon has for the surgery and getting on the same page is really, I think, critically important.
We don't want to be thinking I'm going to be 100% pain-free or symptom-free when the doctor's knowing that that's not a realistic expectation. And no one should undergo really any procedure unless they understand what it's going to accomplish or hopefully will accomplish. Singing
Right.
from the same sheet music, right?
Right, exactly.
Can you share with us the type of research that's currently being done? You mentioned about the nicotine and also the research with, I'm giggling about Marines. My husband's a former Marine. I can just kind of imagine, I don't picture a research nurse saying, now you're in group B that will have bed rest. I can hear somebody screaming at them after they've been semperfied. They better get in bed and probably not move or breathe too much versus get out there and run, right? Oh my goodness. But I'm sure there's other research happening in the lab or happening as clinical trials to see what can we do to prevent or alleviate patients from suffering with back pain. Can you tell us what some of that research is currently? And what do you see on the horizon, perhaps, going forward that may provide even new treatments and remedies?
So I'm going to divide the two topics of research into two big buckets. One is what research we have now ongoing in the clinical realm that is having an impact on patients right now. And then the other is what research we have in the benchtop that might translate into something useful for patients 10, 15 years from now. So in the immediate term, things that the medical community are really focusing on are really identifying the characteristics of patients that can be modified to get rid of pain. These are what are called cognitive behavioral characteristics of patients. Everyone's different. Everyone has a different approach or perspective on pain or activity and has different ways in which they will get better. And figuring out and understanding a patient's perspective and what sorts of tools will be good tools to use to get someone motivated to do physical therapy or motivated to take their medicines is a very important aspect of care. And that's, I think, again, part of the listening of physicians to patients and patients communicating to physicians about what their needs and abilities are. So that's, I think, research that's going on now that's having an immediate impact and affecting the approaches that are taken to physical therapy, medications, other types of pain management around back pain. That research is going on now, and I think has had an impact on care for back pain. The treatment of back pain from a long-term perspective, there's a couple of areas that are being worked on, and they're not yet really at clinical trials, but they involve perhaps medications that could be used to intervene on the development of arthritis in the back. They're in very early phases to see if you can slow down or reverse some of these changes in the disc and the facet joints to sort of either slow it down or reverse it. That is a long way away, probably 10 or 15 years away of even potentially having an impact on treatment of back pain, and likely won't, but that's some of the basic research. There's a lot of work ongoing on medications for bone health. We've seen a lot of advances in that recently and are benefiting from all the various types of medications that can be given to either restore bone strength or keep it from weakening, bones from weakening. So that, I think, is the other area that is treatments that are current in the pipeline to be used in the future and in ongoing. Those are the two big areas.
That's great. I'm always pleased to know that we aren't just settling for where things stand today, that we're always looking to figure out, is there something better in the future that we would be able to offer patients, whether it be for prevention or management. That is good to hear. One patient population that we have not talked about, and I just want to touch on it, are women who are pregnant. And oftentimes, particularly as that baby's growing, her spine is shifting, and as that baby gets bigger and bigger, her spine's kind of like made the letter C back there. I'm curious to know, are you ever have patients that are referred to you when they have low back pain and they're very pregnant, or is that something that obstetricians have, I hope, learned to manage in some manner by getting advice from you?
Back pain in pregnancy is a very common condition, and obstetricians are very skilled at treating most of that. There are instances where patients have sciatica or other conditions that will come up that need management by someone like me. In most instances, those treatments are non-operative, so we are really trying to get someone through the pregnancy. And fortunately, most resolve once the baby's been delivered. Now, the other thing that also happens is, once you've been pregnant and you've delivered and you now have this added responsibility and stress of a young child and have to lean over, bend over, you've often had a cesarean, it's a lot of stress on your back. Many people will have back pain around the time just after the pregnancy, and that needs to be addressed and usually treated with non-operative measures and core exercises and perhaps medications. And those medications need to be given and taken with the knowledge and blessings of your obstetrician, especially if you're breastfeeding. Back pain in pregnancy, fortunately, is something that typically is short-lived, goes away after you've delivered, needs to be managed while you're pregnant. That management's usually by your obstetrician, rarely needs the advice or help of a spine surgeon.
Thank you for joining us today to hear about the causes, symptoms, and treatments of back pain. And thank you, Dr. Riley, for taking the time out of your schedule to educate us on the complexity of back pain. We hope you will join us next month for another educational and informative podcast featuring another Johns Hopkins medicine expert. In the meantime, I invite you to visit the A Woman's Journey website at hopkinsmedicine.org/A Woman's Journey to sign up for a monthly e-letter, read about upcoming podcasts and programs, and to sign up for our upcoming free Conversations That Matter webcast. Thank you again so much, Dr. Riley.
My pleasure, Lily. Nice to talk to you.
Thank you for listening to A Woman's Journey podcast. Join me, Kelly Gear-Ripken, your host, Lily Shockney, and a variety of Johns Hopkins experts on the first Thursday of each month to learn about medical advances in women's health. A Woman's Journey is grateful for the unrestricted educational grants from HRH Foundation that supports our podcast series, Insights That Matter. For more information about A Woman's Journey's virtual programs occurring throughout the year and our monthly webcasts and podcasts, visit our website, hopkinsmedicine.org/A Woman's Journey. Like us on Facebook and Twitter, and visit our website at hopkinsmedicine.org/A Woman's Journey. Until next time, stay well.